Hi everyone, welcome. So, as we wait a couple minutes for others to join, and before we get into the more heavy stuff, we just wanted to take a second and lighten the mood. So, we broke down a few classic insurance mess ups here into a bingo board and wanted to throw it to the audience to ask yourselves which bingo square or squares apply to you. Feel free to play mental bingo, or if you're feeling brave, then you can go ahead and drop it in the chat. And just remember that these moments are way more common than you might think. So, we'll just take 1 or 2 more minutes here and then we'll jump right in. All right, so in the interest of time, I'm going to go ahead and get us started. I'd like to welcome you all to today's session, Decoding the Fine Print for 2026 ACA Open Enrollment. Thank you all so much for being here. We're really excited for today's conversation. My name is Hallie Ray. I'm the Deputy Director at No Patient Left Behind, and I'll be guiding us through today's conversation. During this morning's discussion, we'll be spotlighting several things, including what's broken in ACA marketplace coverage, what's changing heading into 2026, and how families can shop smarter, even when the system seems designed to confuse us. Just a few housekeeping notes right off the bat. This webinar is being recorded for those who joined late or if you need to hop off and revisit later. And we'll have both the live Q&A and chat functions running throughout the entirety of today's session. So please feel free to use them and engage and share perspectives as we go. Just a quick disclaimer, our focus today is on ACA marketplace plans exclusively, so we will not be covering Medicaid or Medicare in today's session. And with that, I'll go ahead and pass it off to our Executive Director here at NPLB, Peter Rubin, who will introduce our expert panelists for today's discussion.
Awesome. Thank you, Holly, and thank you everyone for joining. Happy Monday, happy New Year. Really, really happy that that you folks are taking time out of their day. It's a really consequential time of year, not only because we're all starting a new year, but also because of the ACA open enrollment ending in a week or so. And so we thought we would gather some really smart, interesting folks to help decode the fine print as you think about choosing a health plan. And we're really lucky to be joined by uh, a diverse panel, but most importantly, Noam Levy from KFF. I think what's awesome about Noam is he's probably talked to more patients about this issue over the last several years and really is an expert in understanding the open enrollment. He's also like one of the nation's leading health journalists when it comes to consumer debt and health plan design. And so we're just really lucky to have him join this call and share his expertise. In addition to that sort of meta expertise, we also have a few folks from our patient advisory council who can help personalize from, I think, different perspectives. First, we have Carol Harris, who is a rare disease advocate. She's founder of a really cool organization called Avery's Hope, which brings insight into sort of what happens to families stuck just above the Medicaid threshold and nowhere to turn, and which is also why I think navigating these ACA plans for people who are above Medicaid is a huge issue, whether you're a parent or someone who's doesn't have their own health insurance. Heidi Floyd is also joining us. She's a breast cancer patient advocate. She's got decades of experience helping folks navigate sort of the financial toxicity that goes along with the toxicity of cancer attacking your body. And then lastly, we have Tony Newburn, excuse me, who is also a member of our pack, but he is a MML patient advocate. He's an educator on access and affordability. He's also an excellent trainer, and he can help you not only navigate how to get in better shape, but also sort of how to navigate the high cost of treatments when health plans don't necessarily cover the product prescribed by your provider. So with that, I thought we'd pass it over to Noam to lead us off with sort of the big picture of what's out there and what we should be thinking about before we get to the individual perspectives. Noam?
Thanks so much, Peter, and thanks for including me in the call. I think you're absolutely right. It is a really important time of year for folks to be thinking about health insurance, and I know it's a daunting time as well. Just to give you a little more background, as Peter said, I cover healthcare for KFF, which is a foundation based here in DC and California. I spent most of my career covering healthcare for the Los Angeles Times, and I guess I'll start off just to give a little bit more of a underscoring the importance of health insurance and picking the right plan by talking a little bit about the problem of medical debt, which I'm sure will not be a surprise to any of you who are on the call. I know it's not a surprise to folks who work in the patient advocacy space because 100 million people in the US have some form of healthcare debt. And so these are generally people who have health insurance. But as I'm sure, again, all of you know, everybody in this country, unfortunately, is probably just one large medical bill away from getting saddled with debt. And while health insurance can protect you against the most catastrophic forms of medical debt, it can be really important to choose the right plan because if you're not in the right plan, those bills can go from a few $100s to a few $1,000s to tens of thousands of dollars really quickly. We spent several years researching the extent of medical debt in the United States. We did what I think is still the most extensive poll to really get an understanding of just how big a problem this is. And here are a couple of real quick facts to just kind of, again, I'm sure tell you something that many of you already know. But not only do we know that 40% of US adults have some form of healthcare debt, that's medical or dental. We know that more than half of them have had to make a difficult sacrifice, like cutting back on food and clothing, changing jobs, changing where they live. And we know that many people, 1 in 8 of those folks, owe more than $10,000, which, that's it's a lot of money. We know medical debt is a leading cause of bankruptcy filings. And I just want to end, I guess, by just underscoring again that most of these people have health insurance, but they probably don't have a plan that protects them adequately from the kind of medical bills that unfortunately our system saddles people with on a daily basis. So thank you again for having me, Peter, for No Patient Left Behind, and look forward to hearing from the other panelists.
Thank you so much, Noam, for helping us set the stage and for really showing the massive scope of this problem that we're aiming to address here today. I'd now like to move the conversation over to Tony. Tony, you've seen firsthand how these numbers can play out in real life. For many patients, medical debt and coverage gaps are not abstract, they are daily realities. Can you share how this burden deepens inequities, especially for communities who are already marginalized? Tony, I think you might be muted.
Yes, sorry, thank you. And thanks again. Thanks everyone for joining us. And thank you for the time. So this time last year, as I prepared for CAR T therapy, my days were filled with weekly induction chemotherapy, an echocardiogram, a PET scan, a bone marrow biopsy, CAR T cell collection, countless lab draws, and consistent clinic visits before and after treatment. So many people may shy away from therapies like this because of the perceived cost. But the truth is, you don't fully understand the financial impact until you're in the middle of it. Medical debt isn't evenly distributed. We know that Black and Hispanic adults are more likely to carry medical debt than white adults, even when they're insured. And in rural communities, people are often hit harder because there are fewer in-network providers, which leads to surprise bills. So when we say medical debt is just the tip of the iceberg, we really mean it. This isn't just about numbers in a report. It's about the live everyday stress that people live with, even when they've done everything right and have coverage. And too often that burden lands on communities that are already facing inequities.
That's such an important point, Tony. Thank you so much for sharing. And as Tony mentioned, debt is really only the visible part of the problem. It's just the tip of the iceberg. But beneath the surface are all these structural gaps, right? The policies, the tripwires, the fine print, etc., that make people often feel lost in this complex system. And part of that confusion comes from the actual language itself. So you shouldn't have to Google search when you're trying to figure out which health plan will give you the coverage you need just to figure out what each word means. So to address this issue, I'd like to hand it over to Heidi to walk us through some of this complex jargon. Heidi, when patients try to make sense of all of these acronyms or believe they've got good insurance, where do things usually fall apart and where do the biggest gaps show up?
Thank you. Yes, echoing everyone else, I think it's really, really great that we're addressing this. I can tell you that for me, it fell apart the moment my doctor opened his mouth and started telling me what type of cancer I had. And it was like during that time when you watch Peanuts and the teacher is talking, okay, you have cancer, aggressive cancer, stage, everything was gone. I could not understand anything he was saying. And it wasn't that he had, it wasn't that he was speaking another language per se, but in reality, he was. He was using an acronym, and so was his entire staff. So the nurses, the people that checked me in, they were all using words that I didn't understand. And that goes to registering for insurance as well. People will often toss out terms you have no idea. And there's a list of them on the screen now. Obviously, the big one is ACA. We know that it's the Affordable Care Act, but there are different names that we call it. The media will call it something, so like you have to kind of be aware and do a deep dive. Don't be afraid to Google, I would say, but also just with a grain of salt. So know these things. CSR is the cost sharing reduction, which could be extra discounts. I think those are really crucial to know. EHB, essential health benefits, doctor visits, things like that, prescriptions, all of these matter. OOP, out of pocket, that means this is what you are on the hook for. That's really huge. HSA, this is fantastic. This is a health savings account. If you have one, you can use it for things like prescriptions and even like eye care, dental, things like that, down to Tylenol. So like these things are important, the pain reliever of your choice. PPO, preferred provider organization, and EPO is exclusive provider organization. This is a one that's kind of picking up speed that I've seen. Lower cost insurance that only covers in-network doctors. And I love the bingo card that you put up because the out of network was on there. And unfortunately, I had several bingos on that list. So that's where we are on our acronym soup. For our myth busting, this is still Heidi Floyd, right? Just checking. I don't want to step on anybody's shoes.
Yes, go ahead, Heidi.
So there's just different things that we kind of think about as we go, just based on stereotypes and things that we've learned. Gold and platinum, that means they're the very best, right? Well, it could very be if it's right for you, but it's not. That doesn't mean that it's necessarily the right thing. Because of how we've been taught to think about things. In some cases, silver plan can have better benefits and deductibles have to be considered. What's considered best depends on each individual, much like medical care now. Everything's being designed for you, your specific genetic makeup. The same thing applies to your insurance plan. It relates to you and your family or whoever is on your plan, not your global, not even your neighbor. So it's very different. My coverage automatically rolls over. I don't have to worry about it. Is that true? No, it is not. Deductibles have the potential and do go up every year. You cannot assume that anything is going to stay the same. It takes time, it takes effort to research, but it's so crucial. Finding out what your out-of-pocket costs are, and you have to remember that it starts all over again, even if like this past month has been a really hard one financially for me. And I was trying to cram everything I could into the end of the year so that I didn't have to cross the January threshold and start with my new deductible and out-of-patient costs, but I couldn't make it. So you just have to be hyper vigilant about that. And once I pick a plan, is my network locked in for the year? And this, of course, means no, because things change. Insurance companies contracting with hospitals and doctors, that changes far more frequently than we realize. And that's something that you have to be vigilant about. And by that, I mean, they will send you emails. They're supposed to send you emails. They're obligated to send you things like that. But if you have at one point relegated them to spam, they could be sending you all this information that you can miss. And it's really important that you stay on top of things, because your provider may leave and go to a different network and you may not know, or the nurse didn't tell you, things like that. Drugs can be re-tiered. This is important. You have to make sure that you're aware of what costs are coming in. So it's just a matter of hypervigilance and paying attention and just making sure that you really read everything, even if it's long and detailed. Stay on top of it as best you can.
Thank you so much, Heidi. And now we'll hand it over to Peter to talk through this distinction between bronze, silver, and gold plans and how it can apply on the open enrollment marketplace.
Thanks, Hallie, and thank you, Heidi, for walking through a lot of the sort of myth facts earlier, and it's really just important to take that step back. And there's a lot of acronyms, there's a lot of words, there's perception, and then there's reality. And I think when it comes to health plans and choosing your coverage, you really need to think about you and your experience and what you expect versus kind of what it may appear like on the paper itself. So you do have this concept of, people think bronze is sort of the cheapest and platinum is the most expensive, and platinum guarantees that no matter when I get sick, it'll be covered, and bronze won't. That's actually not the case. Health plans have done a really good job the last number of years of optimizing their revenue management and not necessarily optimizing your care management. And so as you think about the difference between bronze, silver, gold, and platinum plans, don't just think about the premium and the deductible. Make sure that if you anything from allergies to cancer that you act and whatever drugs that you are on, make sure that your plan actually covers your doctor, covers your drug, even though no one thinks. Even though you're not faking cancer to get free chemotherapy, sometimes the health plans think that you are, or not that I say that facetiously, but the reality is that you want to make sure that if a doctor prescribes a treatment and the insurer authorizes it, that's affordable to you. So regardless of whether or not on paper it says you're paying 40% or just 10% of the total actuarial value of a plan, the reality is that really think about and understand your individual circumstances, your individual doctors, your individual treatments and drugs, to make sure, whether they're brand or generic drugs, to make sure that your health plan is providing you with appropriate coverage for when you get sick, not just making it affordable for when you're healthy. The other piece is, we'll have all this information online. This sort of this checklist I just sort of mentioned briefly, really, how often do you use care? Are you eligible for extra benefits, particularly around this whole issue of premium subsidies, but also cost sharing reductions, not just at the federal level, but at the state level? Really reconfirm whether or not you are or are not eligible for Medicaid or Medicare or your employer plan, because those will all factor into this. Once again, the medication piece is very important. Make sure that your plan's not overcharging you for your brand drugs or for your generic drugs. And if there is a higher monthly premium, what are you getting in exchange for that? And if it means that when you get sick, if you expect that someone in your family is sick or you think might get sick, that might be a better deal to make sure that you have the protection you need, particularly if you are suffering from a particular condition. We'll have all this stuff online, but really it's more than just the fancy name, but really kick the tires and understand the health plan before you enroll. But most importantly, do make a conscious decision and enroll.
Thanks, Peter. And as Peter mentioned, we're building out a resource hub that will live on our NPLB website, and we'll be sharing that link with everyone who's on this call. So that will include things like that checklist, but also the terms and definitions that we went over earlier and other helpful links. So that is coming soon. Now I'd like to move us beyond the basics and move into where some of these hidden rules are that we need to be aware of during open enrollment. So tripwires that can really catch patients off guard and often prove more costly than we expect. I'd like to go back to Heidi on this topic. Heidi, when you think back on your own experience, what were the hidden rules or unexpected traps that blindsided you, the things you wish someone had warned you about?
Oh my goodness, the list is kind of endless on that one. For me, I had no idea that the first time I went to get my oral chemotherapeutic, I was told that it would be about $25, but it had not yet been approved by my insurance company. So it was actually $985 a month. And that was, to me, that's a staggering sum of money. So it's kind of, it's again, much like we said in the, everyone has kind of put this through mind. You have to pay attention to everything that's going on. Copay is a huge one. So there's a
deductible. And these are the things that you hear about on every advertisement. So even though they'll say, if you can't afford your medicine, please contact so-and-so. These are the coupons that we're talking about. These are the manufacturer rebates that you have to be quite careful about. So if this was the same practice, and we have something on this slide that kind of shows you how detrimental it is. If this was the same practice that had been applied to college tuition, $10,000, you get a $3,000 scholarship. You think that it's $7,000. However, it didn't. It took that money. The college took the money and didn't apply it to the tuition costs. It took it, but then removed it. So you're still told that you owe $10,000. So it's applying it, but it's not applying it to the proper code. There are so many ways that they have that has happened that has caused this kind of the seepage, as it were, of funds. 2/3 of all individual marketplace plans have a copay accumulator, and it's something we have to look for and vigorously fight against. There's wide state variations, state to state. So I'm in Georgia. Mine does not look like my sister's in Illinois. So just be very vigilant. And if you have information, it's so good to share with other patients. If you have found the key to living in Georgia and you know what the answers are, share it wide, because the more people that we help, the better the system will be.
Thank you, Heidi. It's such an important point. And copay accumulators, unfortunately, are not the only fine print trap. So now...
Really, I can't hear you. I don't know if it's just me.
Oh,
I can hear you fine.
okay. So now I'd like us to move back to Tony. Tony, can you tell us about the coinsurance and copay debacle and walk us through a bit of that distinction between the two, and also how it can affect patients? Because I think this one is one of the really confusing pieces about this.
Sure, let's definitely discuss this shipping case analogy, the fine print traps, and with coinsurance and copay confusion, the hidden math behind it all. So let me break it down in a simple way, because these terms get confusing fast. So a copay, it's like paying a flat, say, $50 shipping fee. It doesn't matter how big or how heavy the package is, you know exactly what you're paying. It's predictable, it's manageable. Now, coinsurance is different. Instead of a flat fee, you're paying a percentage, say 20% of the total cost. So if the shipping cost is $1,000, suddenly you owe $200. So here's where it really becomes a problem: specialty drugs. These are like shipping a huge, fragile package that needs special handling. The cost is already high, and because you're paying a percentage, your share can skyrocket into hundreds or even thousands of dollars. And this is why it matters so much. Patients often walk in the pharmacy counter thinking they'll pay a reasonable, predictable amount, and then they're shocked when they're told they owe far more than expected. The sickest patients, the ones who need breakthrough or specialty medications, often end up paying the most simply because their medication is expensive. So the takeaway is this: copays are predictable, coinsurance is a moving target. And for many patients, that moving target can turn what should be affordable care into real financial stress.
Thank you, Tony. That's such an important distinction. And that shipping analogy is really helpful to understanding the difference between the two. And I saw someone put a question in the chat. So if any of this, if brings up any questions, please continue to drop them in the chat. And we may even have time at the end for one or two addressed verbally. But if not, we can answer them in the chat as we go. So unfortunately, the confusion does not stop there. I'd now like to move it over to Carol to discuss formularies. So formularies are the list of medicines that an insurance plan covers, but unfortunately, this can actually change throughout the year. So even if families manage the shock of copays and coinsurance, they can still be blindsided mid-year when a drug suddenly disappears from their covered list. So Carol, I know you've worked with countless rare disease patients and their families through these exact issues. I'd love to hear from your experience with this formulary issue specifically, since we know that formulary changes often hit rare and chronic disease patients the very hardest. From your expert experience, what should families know about how these exclusions play out in real life?
Thanks, Hallie. Well, as you mentioned, a formulary is simply the list of medications, formulas, treatments your insurance plan agrees to cover. And once you've paid the high cost of your premium, we tend to believe that throughout the year, all of those drugs and treatments are going to be covered. But unfortunately, what I think many people don't realize is that that list can change anytime during the year. And it can dramatically change from one year to the next, even if your diagnosis remains the same. And when that happens, the impact is not theoretical. It's really very personal. So in real life, a formulary exclusion means that a medication you or your child has been stable on for years is suddenly labeled non-preferred. A medically necessary formula is reclassified as nutritional instead of medical. And a treatment your doctor prescribes is technically available, but only after months of appeals. And so there are some things you can do. You can request an exception, you can file an appeal. But for families managing rare or complex conditions, these are not small inconveniences. These are a disruption that can affect the growth of the patient or the child, pain control, nutrition, development, and in some cases, even survival. So here's how it plays out. A family enrolls in the marketplace plan because it covers a specific medication or a formula listed in the plan documents, which is why you choose that particular plan. And you start the year optimistic, hopeful. Then a letter arrives, sometimes buried in an online portal, very sneakily stating that as of a certain date, coverage has changed. Very similar to going to, let's say, the train station to catch a train or to the airport to catch a flight, and your trip's been canceled. Now, if I'm waiting for the train, I know that I can get on the next train when it comes. But if I'm a rare disease patient and my formulary has been canceled, it's not such an easy situation. So they're told through the insurance company, try this alternative first, submit another prior authorization, or appeal the decision and wait. And while the appeals are pending, families often face impossible choices. They have to pay thousands of dollars out of pocket to get the medication that they need. They might stretch doses or formulas. They're delaying care, or they risk regression by switching treatments that aren't equivalent. Marketplace plans are especially challenging because they often limit access to specialty medications, exclude medical foods or formulas, change formularies more aggressively to control costs, and offer fewer out-of-network options for specialty care. And rare disease, by definition, is specialized. And so what families should know is that formulary decisions are financial decisions and not medical ones. They are made to manage cost, not the complexity of the patient or the child. So what can families do? You have to read beyond the premium. Look very closely at the drug formulary, not just whether a drug is listed, but its tier. Very, very important. the coverage of medical foods, formulas, and even supplies, prior authorization and step therapy requirements, out-of-pocket maximums for specialty care. And most importantly, and I know it can be very time-consuming, but document absolutely everything. Keep records of medical necessity letters and any kind of messages that your team has sent through my chart. And work with your medical team to appeal any decision. And I just wanted to share a very quick story about a family that we supported whose child had pediatric Crohn's. This child had been on a drug called Remicade most of his life, and it worked beautifully. Well, apparently that's very expensive because it has to be given either in clinic or in a hospital setting because it's an infusion. And the insurance company wanted them to change to Humira. Well, if you come off Remicade, you can't get back on. So if Humira doesn't work, now the child was going to be left without a possible solution. And so the family paid out of pocket for about, I think, 5 or 6 months in order to get the drug that the child needed while it was in mediation. So it's very, very important that you really fight with your medical team, because otherwise you can really be left in the dust because of formulary exclusions.
Thanks, Carol. And just want to add that while, Carol's expertise is helping rare disease patients as well as other patient groups, and formulary exclusions hit the rare disease community very hard because there's often not a lot of other options for that community. This is something that happens to all patients. So please be sure to look into this, regardless of what your situation or condition is, because it can really happen for all patients. All right, so thank you, Carol, Tony, and Heidi, for shedding some light on each of these 3 fine print traps that we wanted to highlight today. Whether it be copay accumulator programs, coinsurance versus copay confusion, or formulary exclusions, these obstacles will remain important things to consider as we head into 2026. But as the year changes, we also wanted to highlight some of the ways that the marketplace itself is shifting and changing, and what are some of the newer things that patients should be looking out for as we head into the new year, whether that be subsidies or premiums, eligibility, or even enrollment support. So let's go ahead and pass it back to Noam, who will help us take a closer look at what patients are up against heading into the new year specifically.
Thanks so much. So unfortunately, as many of you may know already, there are some pretty big changes on the way this year for the ACA marketplaces, specifically the federal assistance that's available for patients. Just to back it up for a little bit here, as again, many of you may know, the Biden administration, Congress after COVID passed enhanced subsidies, which addressed one of the big challenges that the marketplace has faced historically, which was it was very difficult for people, particularly those people who are sort of at the point where sort of middle class to working class and lower income folks meet. It was very difficult for those folks to afford premiums because there wasn't as much federal assistance available. So there was a lot of additional aid that was enacted a few years ago. And unfortunately, it expired at the end of last year. And there had been a hope that it would be renewed. But again, as you may have noticed, the federal government shut down a few months ago for about a month over a fight about these subsidies. Since these subsidies are going away now, unless Congress acts, a good chunk of the roughly 25 million people who rely on ACA plans will no longer qualify for aid. So what does that mean practically for people who are looking to get health insurance on an ACA marketplace? Well, for folks who are making more than about 4 times the federal poverty level, so that's about $60 some odd thousand for an individual, about $125,000, $130,000 for a family of 4, there is no more assistance at the moment. So those folks are going to have to pay full freight for the monthly premium costs to buy a plan on any ACA marketplace. And there are a couple exceptions, and I'll get into that in a second. But that's the big headline here. The second really important thing to know is that because these subsidies are going away, and because there's been a lot of uncertainty in insurance markets around the country, premiums are also going up a lot. And if you've been out there looking to renew your plan or shop for a new plan, you have no doubt noticed that a plan that might have cost a couple $100 a month now is $500 or $600 a month or more. And again, this is falling disproportionately on folks who are in that sort of 250, 300% of the federal poverty level. These are the folks who are seeing this pullback of federal assistance. And so I won't go through all of these big changes here, but I think the thing that to keep in mind here is that people are going to have to be a little bit more creative and probably dig even more deeply into all of these kinds of traps that other panelists here have been talking about, because it may be that a bronze plan with a really big deductible is better for you. It may be a lot cheaper, but there are trade-offs with all these things, and maybe we'll talk more about that in a little bit. I think the other thing is that folks, unfortunately, are going to see that there's a lot less enrollment help out there. And if you've shopped for an ACA plan in the past, it's generally not something that you want to do on your own. I used to help my colleagues at the Los Angeles Times try to understand the health plan options in our company. And even that, for a group of pretty engaged consumers, was a lot to stomach. So unfortunately, the Trump administration is cutting back on aid that people rely on to help decipher the options that are out there. But maybe some of the other panelists who can talk about this with greater knowledge than I can. I know these navigator groups have been very successful in the past. Many of them are still out there. They're just more resource constrained. And if you're lucky enough to live in a state that runs its own marketplace, like California, for example, there are additional options to help you sort through the different health plan options that may be out there. But it's more important than ever to shop around. So I'll stop there and hand it over to everybody else.
Thanks, Noam. And that sort of volatility of the public policy environment on top of sort of changes in how health plans design their own coverage each year can create some uncertainty, which is why we are so interested in No Patient Left Behind around how do we achieve affordability and patient protections, because the ACA wasn't originally called the ACA, it was called the Patient Protection and Affordable Care Act. And so our core belief is that, if a doctor prescribes a treatment and the insurer authorizes it, it should be affordable to the patient. What are your premiums for, whether it's coming from the federal government or from your own pocket. The other piece of this is, once again, no one on this call, none of our kids are faking a disease in order to get free shots. Tony's not faking his MML to get free chemo. These are all reasons why we have insurance. And so for us, we really want to make sure that you're thinking about not only enrolling in the ACA plan by January 15th, but that you're actually thinking about what that plan looks like. Is it right for you and your family? Because what we have seen, we have done a study that have shown that during this time when the federal government basically provide these enhanced premium subsidies, the health plans actually started shifting a higher percentage of out-of-pocket costs on the patients. We found that since 2021, they actually started charging sick patients 36% more in prescription drug costs than in out-of-pocket costs than they were in 2021, despite getting all this huge influx of new lives. So you really need to, not just sort of look at, will this subsidy be there or not, but also think about in terms of what does that health plan look like for me. We also, from want to just, make sure, if you are in a state where, your state did not expand Medicaid, this subsidy cliff will hit you even harder. There's a huge gap of folks, between 300 and 150 in some of these states that did not cover expand Medicaid, where whether it's Georgia or or others, Alabama, Mississippi, you should find out from your own state. The reality is that, if your state has not expanded Medicaid under the ACA, this subsidy cliff will hit your state and potentially you much harder because there's a lot less to fall back on. And moving forward, we would love to see, sort of Congress take a look at coming up with improving the ACA, not just having it be an all or nothing discussion about whether or not there should be subsidies or no subsidies or limited subsidies for ACA enrollees. Our view is that you should also improve the quality of the health plan, not just maintain the subsidies. We'd love to see some type of out-of-pocket cap similar to what that they've done in Medicare, where you cap prescription drugs at $2,000. We've seen members of Congress over the last few years come up with ideas. Most recently, Congressman Auchincloss from Massachusetts has a bill, and hopefully that will be continue to extend across different market segments. So it's not simply about what's happening now, but how do we help improve this for the future? Not just simply about improving the amount of subsidies that go to health plans, but also that the quality of those plans also are improved as part of this process. So, Hallie, maybe you can shift us to sort of how to help people find better resources. And Carol.
Yes, of course. And I just wanted to quickly add that, like Peter mentioned, we've seen some progress on this in Congress, and that's something that MPLB is working to promote. One of the ways we do that is by providing this research that policymakers can then use to justify stuff like this CAP Act that's come out from Congressman Auchincloss. So the thumbnail above it, that will link, the slides will be in the resource hub after this, but that thumbnail links to an out-of-pocket report that MPLB did that got this data point about the 36% increase in out-of-pocket cost shifting to sicker patients. So we're working to provide that research and that database that then will promote change. So working to address that as we go. And we can now move to Carol, like Peter said. So adding on to what Noam was talking about with the Navigator funding. So the Navigator funding has been slashed by about 90%. So families already have fewer guides to help them make sense of these complex choices. I'd like to pass it back to Carol now. And if Carol, if you could tell us a bit about your time running Avery's Hope and what you've been hearing about the financial assistance landscape as you talk to these families and patients, and what are some of the alternative funding programs that people are turning to and that are still available even as funding is drying up a bit right now?
Yeah, thanks, Hallie. There are a number of hurdles, and this is going to sound a little bit scary, but there is hope out there and there are resources available. But realistically, the folks that are really going to be hit the hardest are the patients and the patient families that are just above the Medicaid line. It's when you make just too much to qualify for a number of programs, and you're paying so much out of pocket. Foundation criteria is beginning to narrow. There are fewer grants. Charitable funds are depleting very quickly. So at the beginning of every year, patients and patient families are applying for assistance, and the money goes quickly because there's less of it. Many people aren't aware of the 340B plans at hospitals. Some of the nonprofit hospitals do get a discount on drugs and treatment. They don't always tell the patients or patient families, and that's something to really pay attention to. And although resources are limited, families do have to think about patching different areas to put together to be able to get the support that they need. I think that's really the next section we're going to be talking about, who you're able to reach out to and who you can get assistance from. But one of the things I really want to reiterate is that No Patient Left Behind has a really excellent resource hub. And we worked very hard to put resources out for the patients and patient families that really anybody can access, whether you're an advocate for a patient or if you're a patient yourself. Please don't hesitate to use it. Lots of excellent resources.
Thank you, Carol. So, as she explained, there are several hurdles to be aware of, but there's also still places to turn, and we will be compiling those into the resource hub, as Carol mentioned. But I also wanted to take a second now to just give our panelists a chance to mention one or two things that they know can help patients, so some actionable recommendations before we end the call. So we'll do this round robin style, and if we'll lead off with Carol, and then I'll move us through the rest of the panelists. But just wanting to hear from everyone in a landscape where families often are hitting wall after wall of obstacles with coverage denied, assistance depleted, etc. What have you seen in your experience that actually has made a difference and can make a difference? And where do patients find real lifelines when everything else is feeling a bit like a dead end? And we'll start with Carol, and then I'll move us through the rest of the panelists.
Yeah, so very important is find out who the financial navigator is at your hospital team or in your clinic or in your doctor's office. The hospital billing offices, I know that they're scary places, but they're there to help you, and they will. The social workers at the hospital, if you are inpatient or inpatient with your child, they are a lifeline. They're a lifeline to professional patient advocates who can help you get through this, and do not hesitate to reach out to advocates. Even if it's not in your disease group, we all work together to get you the information that you need.
Awesome. Thank you, Carol. And now I'll pass it to Heidi.
I think I agree completely with Carol. The social worker at the hospitals, or in my case, cancer centers, can change everything. They'll help you in creative and inventive ways that you didn't even think of. So for us, my thing was we had to drive from one state to another to get chemotherapy, and I had little children, and I was pregnant, and it took so long that I had to spend the night, and we were paying not only all those costs, but we also had to pay for a hotel. When I mentioned it to the social worker, she's like, well, we have a connection with the hotel across the street, and we pay them. So you could have one free night, because there was no Hope Lodge at that time. There's nothing like that. So even ways you don't know to ask, they know to ask. And unfortunately, I know too many people that have had to choose between paying the rent or paying for radiation. There are so many nonprofits out there, and if you can Google them, that's my recommendation. If you can't, if you're the type of person who unfortunately doesn't have internet access, and I think that's an unaddressed issue, head to your library, or again, ask your social worker and say, I can't look up breast cancer social services. Can you please help me? And they can help you with things as small as, we'll get you dinner next Thursday, or we'll cover your rent. This is a big thing. So Google, and don't be afraid to ask. Because I know you don't want to. I know you want to say, no, I'm fine, but you are not fine. Go ask.
Thank you, Heidi. It's really helpful. And now I'll pass it to Tony for the same question.
Thank you, Haley. And Carol and Heidi, great feedback on that. I say for me, proactively looping in informed physicians and nurse navigators is essential. It truly takes a village. And my doctors, the nurses, and my medical team became an integral part of that village for me as well. So definitely loop them in, reach out. Don't hesitate. You need the help.
Thanks, Tony. And lastly, to Noam for his answer.
Thanks, Haley. I think I'd say two things. One, building off of what the other panelists said, hospitals in many cases offer assistance through financial assistance programs. These programs have not been terribly well managed in a lot of different places, and they're very complicated to access. But most hospitals do offer aid, basically a discount off of the hospital bill for people making up to, in some cases, 4 times the federal poverty line. And so if you have a big bill, it's worth asking, and you have to be persistent. And if you can't get your application through the process, there are groups like $4 and others that can help you submit those plans. That can help with a big bill. And then I guess the last thing I'd say, just putting on my hat as a journalist here, I know it's a lot to ask for people who are struggling with big bills and dealing with a scary, potentially deadly illness, but speak up. This system is not working, as this webinar and millions of others like it attest. it's not working for patients. People can't afford their bills. They shouldn't, frankly, have to make sense of this alphabet soup. And I think the only way it's going to change is if people hear from people who are experiencing it. So talk to journalists, talk to elected officials, share your stories, and don't be afraid. It's not anything to be ashamed of. This doesn't work for anybody, including very smart physicians that I interview all the time who have no idea how bad it is until they themselves get sick or have a family member who gets sick. So don't feel ashamed, and don't don't be quiet about it.
Thank you, Noam. And to that point, we have a Share Your Story feature on the NPLB site, and it will be included in the resource hub as well. And we really want to center patient voices in this conversation. So that is an easy way to share your story right through our site. And thank you, everyone, for answering the roundtable question. I also just want to flag a few other resources as well, such as appeals, single case exceptions, and if your drug is not covered by your insurance, or if you're struggling with prior authorization, you can actually call the inventors. So you can call the manufacturer of that drug, and they can often help you navigate that situation with your insurer, or even provide some financial assistance, because manufacturers don't create drugs so that patients cannot access them. So they can help you with that. And we have actually designed an AI tool on our site under the Call the Inventors tab where you can put in your drug that you're struggling to get coverage on, and it will provide information for how to get in touch with the inventors to help you with that. So with that, I will hand it over to Peter to finish us out and lead us through a quick Q&A if we have some time at the end. But thank you all so much for your insights.
Yes, and thank you, Hallie, and thank you, team. I just want to reiterate just a few key things that what we were hoping to get out of this webinar, which is one, really make a conscious decision about choosing the right health insurance plan for you and your family. While this is mostly about the ACA exchange plans, whether you get it through Medicare, your parents get it through Medicare, you get it through your employer, definitely go through the book and ask questions, because you don't want to be in a position where you find out and it's too late. The second piece is really around, there's a book that's called Never Pay the First Bill, but the idea that because of the ACA, thanks to the ACA, there are a lot of rights that are given to consumers to challenge and request appeals when your coverage is denied, delayed, or discouraged through out-of-pocket costs or blatant denials. So don't be afraid to call your health plan. Don't be afraid to call the folks that that the panelists mentioned, whether it's the hospital person, someone in your community, a navigator, because I view it as like when your pipe bursts, you don't always try and fix it yourself. You might as well bring in the plumber who does this every day for a living. And the same thing when it comes to appealing health plans. So definitely question everything. Don't be afraid to ask questions of your CMS, your health plan, your state health regulator, to really understand how this plan is going to impact you, or how make sure that they're treating you in an appropriate way. Definitely, please do stay involved with not only follow-up questions here, but definitely please subscribe to our 5 Print series, but also follow us on social media, learn more about what we're doing and how we're doing it, because we do want to try and create a movement to fix insurance, so that it's not simply about whether or not the health plans have more people covered, but that we're covering people with high quality insurance, so that when you do get sick, we all will be patients one day, that it's actually covered. And then lastly, we do work a lot with a group called the Lower Out-of-Pocket Cost Coalition, which is more of a consumer group. If your entity, organization is interested in that, we can share more about that broader group. And let us know how we can be of help to you. So thank you very much for your time, and thank you, panelists, for sharing your expertise and personal experiences. Great. And is there any other questions you want to handle, Hallie, before we go? Or
I think we got all the questions in the chat, but I'll just give everyone like 1 minute. If you want to raise your hand and ask a question, please feel free to, and I can unmute you on my end. So I'll just give a couple seconds to see if anyone has any last minute questions.
All right. What a great way to start the year. 5 minutes back already for your lives. But thank you everyone for taking time out of your first day back. And I hope everyone has a great new year. And please do stay involved, whether it's with us, with your peers, because it's not easy stuff, and we want to make sure that folks have access to what they need. So thank you.
Thank you.